Thanks, Rami, and I'd like to congratulate my good friend Ari for putting together this absolutely wonderful scientific meeting. So I've been assigned the task of talking about the anatomically designed tibia for total knee arthroplasty. These are my conflicts, and they do have a bearing because I'm one of the designer surgeons for Persona. I think one of the earlier speakers spoke about the different tibial morphologies, and particularly in this part of the world, you do come across tibias with varying degrees of posterior slope in the proximal tibia. So I think the real conflict in the currently available base plates, there are three types: the anatomic, the symmetric, and the asymmetric. And our premise is that the anatomic achieves optimal coverage in almost about 96% of the cases. Let's see whether that is in fact the case. I think in this part of the world, most of our presentations are very late. There are often tibial defects, and there's a frequent need to downsize the tibia to be able to take care of adequate coverage. And when we do take the tibial cuts, oftentimes you'll find that the tibial cuts are incongruous. The other point that we see is if we were to use symmetric tibias, there's almost always a portion of the posteromedial part of the tibia which is uncovered and usually needs to be resected and downsized. The other point is, because of the varying morphology of the proximal tibia, if you align yourself to the principles of right-angled cuts to the mechanical axis, sometimes you'll get this type of a clinical situation where you're actually aligned, but you've actually gone through the posterior cortex of the tibia. It's not uncommon to see this. So anatomical matching tibial base plates can facilitate successful outcomes. And I think there are various authors who have alluded to this for a fair length of time. Almost 2 decades ago, Rich Berger mentioned about achieving proper rotational alignment with minimal overhang and good bone coverage. So this is really a conflict of intentions in these 3 functional requirements. The other point which is interesting is, compared to the Caucasian population, the current contemporary tibial base plates cause a morphological mismatch, primarily because of the small size and build of our patients. And there's a differential performance across ethnicities because of the small number of tibial trace sizes in the proximal tibia. So we undertook this study, and we published this in the KSST in 14. We looked at the CT reconstructed tibial surfaces of various Asian populations and 164 Caucasian populations. We resected the tibias at 7 degrees of posterior slope, 0 degrees of valgus, which is really mechanically aligned, and measured off 8 millimeters from the lateral tibial plateau. And we looked at the coverage analysis, tibial coverage between the various ethnicities and the tibial slopes. We divided these into various design, so A through to F. And we looked at A and B, which are asymmetric, and C to F, which were the symmetric tibias. And we can see that there were various levels of coverage and uncoveraged tibias across various designs and across various ethnicities. The coverage varied between 69 and 99%, so you can see there's a huge spread. And the statistically significant improvements in coverage were obtained for Caucasians compared to the Korean and the Chinese designs in some of the symmetric varieties. And most bones without a valid component size were Asian, which really meant that the Asian tibias were more challenging in their anatomical disposition towards adequate and optimal coverage. So the impact of size coverage generally decreased with reduced component ML width, the maximum difference in ML width ranging from only 3% in design A, which is the Asian knee, which is the asymmetric design, to almost 13% in design B. So even in the asymmetric, there was a difference between the 2 ethnicities. And this graph basically just shows the disconnect between the coverage between the Asian and the Caucasian population. So the ability to cover the resected tibial plateau across the various tibial component designs varied, and it was the variability was more than ethnicity, and as the majority of bones without a component size were Asian, it is generally suggested that smaller sizes of contemporary tibial designs do not fully accommodate variations in the small bone anatomy. Oftentimes, to achieve adequate coverage, you tend to internally rotate the tibial component, which causes very unique kinematics, reduces implant longevity, and causes patellar malfunction. So ensuring proper rotation without undersizing is the key to adequate tibial coverage and achieving good alignment. And this is particularly important for non-anatomic tibial designs. So this was really our paper. We did a digital evaluation of tibial component positioning, the impact of rotational alignment on undersizing and bony coverage. We looked at 150 healthy tibias. We then did our resection, taking 8 millimeters of the lateral tibial plateau, and again we did the same evaluation across ethnicities, and we looked at the maximum coverage on the largest size that we were able to achieve without internally rotating the tibia. And what we found in this was that the impact of rotational alignment on undersizing and bony coverage was best achieved by using an anatomical tibial design. In this case, it was the Persona design. And you can see over here in this the design A, which is the Persona, achieved the maximum and the best coverage. A and B were pretty good, and there was a fair amount of disconnect between the other 4 sizes. And across designs, the coverage reduced mean coverage from 93% to 85 to 92%, which meant that symmetric designs had a challenge. And the mean distance from the component to the posterior medial cortex increased with the anatomical designs. So across designs, greater than 5 degrees of component internal rotation was required to achieve maximum coverage in the more anatomical designs, again reinforcing the fact that the asymmetric and anatomical design were the better ones. So in conclusion, we achieved the highest amount of coverage and placement with best posterior medial cortical support with the anatomic tibial design. Undersizing was required in very few cases, only 3%, and in most cases a single size downsize was achieved and was adequately sufficient to ensure excellent coverage. So in conclusion, for designs B to F, which was really the asymmetric and symmetric, ensuring proper rotation, alignment forces, component undersizing was the key. We had to do this, thereby compromising tibial coverage and cortical support, and potentially theoretically affecting component fixation and stability. Whereas in the anatomical design, we had consistently higher tibial coverage, reduced propensity for malalignment, and better posterior medial cortical support than the other 5 designs that was investigated.